Zoom presentation for World Mental Health Day 2022. I'm Sue Carline and I promote mental health and wellbeing through spiritual insight based on a New Testament scripture, 2 Timothy 1:7, that says, God has not given us a spirit of fear, but one of power, of love, and of our mind. So based on that, I acknowledge the Creator Spirit in our midst. I'd like to extend a very warm welcome to our presenter, Professor Harold Koenig of Duke University, North Carolina. And I just thank you very much for being here at what is your time, 4 o'clock in the morning, which is a rather rude hour to be disturbed, but we appreciate enormously for you being with us. Could I say, I've got a message on my screen. It says, please ask the host to give you permission to record.
Go ahead and say yes.
So it's just got closed, so I'll close. And if I'm not recording, then at least you're recording, are you?
Yes.
Wonderful, excellent. I'd also like to acknowledge the traditional custodians of Lutruwita, or Tasmania, and I'd like to honour Milton Perkins, who has been a wonderful supporter of what I've been doing, Joni Galbraith and Karen Daniels. So before I introduce you, Professor Koenig, I'd just like to let everyone know that it is being recorded, that there will be a time for questions afterwards. So if you can just write them down or raise your hand if you've got a question to ask. And on that basis, I'll now introduce you officially. So more universally known affectionately as Dr. K, Harold is a highly credentialed medical practitioner and researcher with an extremely impressive and extensive list of achievements to his name, many but not all of which are mentioned in this bio sketch. Dr. K completed his undergraduate education at Stanford University Medical School at the University of California in San Francisco, and furthered his qualifications in geriatric medicine, psychiatry, and biostatistics training at Duke University Medical Center, DUMC. He is on the faculty at DUMC as Professor of Psychiatry and Associate Professor of Medicine, and he is also an adjunct professor in the Department of Medicine at King Abdulaziz University, Jeddah, Saudi Arabia, as well as adjunct professor in the School of Public Health and at Ningxia University, Yinchuan, China. And please excuse my pronunciations. Dr. Koenig has close to 600 scientific peer-reviewed academic publications, 100 book chapters, and over 55 books in print or preparation. His research has been featured on many national and international television programs, including ABC's World News Tonight, The Today Show, Good Morning America, and others. And he has appeared on hundreds of national and international radio programs and in newspapers, magazines, including Reader's Digest, Parade Magazine, Newsweek, and Time. Dr. Koenig has given testimony before the US Senate in 1998 and US House of Representatives in 2008 concerning the benefits of religious involvement on public health. And he is a recipient of the 2012 Oscar Fitzer Award from the American Psychiatric Association. The 2013 Gary Collins Award from the American Association of Christian Counselors, or the AACC, and the 2021 Frank Minerth Award for Excellence in Christian Psychiatry and Behavioural Medicine from the AACC. He's a former editor-in-chief of the International Journal of Psychiatry in Medicine and is currently an associate editor of the Journal of Religion and Health. Finally, Dr. Koenig is the lead author of the 2022 third edition of the Handbook of Religion and Health, Oxford University Press, and the lead author of the 2022 book, Spiritual Readiness, Essentials for Military Leaders and Chaplains, and he has co-led the 2022 Professional Development Training course that trained over 1,000 US Navy Marine Corps, Coast Guard chaplains and religious program specialists on spiritual readiness for combat operations by military personnel. So that's an incredibly impressive bio sketch, Dr. K, incomplete, but I welcome you and I thank you for presenting for us now. I hand it over to you. Thank you.
Thank you, Sue. I'm going to go ahead and share my screen. And hopefully you all can see my screen now.
Yes, thank you.
Yes.
Can everyone see that?
Yes.
Yep.
Good.
Very good. I'm going to go ahead and hide the meeting controls. And so it's a real pleasure for me to talk to you all. This is a topic, religion, spirituality, and mental health that I've been studying and researching for almost 40 years now. I'm going to, first of all, be talking about definitions. Definitions are very important. Then review some of the research on religious involvement and mental health. Next, I'll present a theoretical model helping to explain how religious involvement influences mental and social health. Very briefly, look at some religious and spiritually integrated psychotherapies that are now being used in mental health care, provide some conclusions, and then provide you with some further resources if you want to know more.
Thank you.
So here, this is a very, very controversial topic. Whether or not religion or spirituality should be talked about, and whether they're the same or whether they're different. So religion tends to be unpopular, and it is potentially divisive because people believe different things and they don't all agree with one another. Spirituality, on the other hand, is more popular. It's inclusive and common to all, but it's largely self-defined. There's no real common agreement on what exactly spirituality is. Now, through most of recorded history, spirituality and religion have been considered the same. This has been true up until only about 30 years ago. Around 30 years ago, in the 1990s, spirituality became to be separated from religion. So let me show you, let me visually illustrate what has happened over the last 30 years. If you look here, this is the traditional understanding of the term spirituality and religion. Basically, there is religion here, and spiritual people were a subgroup of religious individuals who were considered deeply, deeply religious, whose lives were centered on their religious faith. The spiritual people were oftentimes considered the clergy persons. And so then you had the more superficially religious people, the deeply religious, the more superficially religious, and those who are neither spiritual nor religious. Now, when conducting research on comparing those who were deeply religious versus those who were superficially religious compared to those who were not religious at all, it was fairly simple. You could measure religiosity, and those who scored high on those scales were considered the deeply religious or the spiritual. And then those who scored in the middle were more the normative religious. And then those who scored on the bottom of this scale would be considered non-religious or secular. And you could then compare their mental health, their positive mental health, meaning and purpose, connectedness with others, their well-being, their peacefulness, their hope. And you could look at their negative aspects of mental health, depression, suicide, anxiety, addiction. And then you could also look at physical health, because we know that mental health influences physical health, cardiovascular disease, cancer, mortality, through the mind-body relationships, through psychoneuroimmunological mechanisms. So this could all be understood and made sense of. Now, spirituality has expanded further. You can see that spirituality here in the more modern definition has expanded beyond religion, so that you can be spiritual but not religious. You can be religious and spiritual, but like I said, you can also be spiritual but not religious. And then, of course, you can be neither spiritual nor religious. This is still perfectly adequate, because you can compare the mental and the physical health of these three groups: the religious and spiritual, the spiritual but not religious, and then those who are neither religious nor spiritual. However, things have expanded even further in terms of spirituality. The reason is because researchers have had a difficult time describing individuals who would refer to themselves as spiritual but not religious, using the term spiritual. That's created a real dilemma, because spiritual tends to be a religious word, and using a religious word to describe oneself when one is not at all religious, it creates a lot of confusion. So in any case, this has created kind of a vacuum here, which has caused spirituality to expand further in order to try to identify characteristics of those who are spiritual but not religious. So this is what's happened. So this is currently the way spirituality is measured when people are doing research. And there's a problem here. The problem is that spirituality is now being defined a priori as good mental health, as positive mental health, without a single research study being done. This is done entirely by defining spirituality as good mental health. What this does is that it really biases the findings in favor of spirituality, because those who are secular and those who are religious don't have a chance, because these are very distinct constructs that are now being compared with spirituality, which is defined as mental health. So naturally, those who are spiritual will always have better mental health than those who are religious and those who are secular. Okay, so that's kind of the definition. Now, my final words on this is, when I discuss the research, I'm going to be mostly using the term religion, despite its unpopularity, since that is what can be measured and is sufficiently distinct from the outcome to avoid these conceptual overlaps. Now, when measuring spirituality, I would recommend for research that can be done, but measures should not be contaminated with positive psychological states or positive character traits, such as meaning and purpose, connectedness with others, and hope and existential well-being, which is currently being done. This will help to avoid defining spirituality a priori as good mental health and will avoid the tautological associations that would otherwise result. So that's in terms of research. Now, I want to distinguish that from clinical settings. In clinical settings, there is a different goal. The goal in clinical settings is to maximize connection, engagement with patients, and conversation. So spirituality is the perfect term to use because it can then be defined by patients themselves, and then the clinician will address it in that way, in however the patient understands the word spirituality. It may mean religion, it may not mean religion. So it's a great term for clinical engagement in clinical practice. But when you're talking about research, which is trying to identify factors that affect mental health or affect physical health, something that you can intervene on, we're really going to have to talk about religion. Okay, so that's my thoughts on definitions. Now, I have to admit that not everyone agrees with me on my perspective there, but I think I have good scientific rationale to back it up. Okay, so let's look at religion, spirituality, and mental health. Let's look at the research. Now, if you're wanting more information about this, if you're wanting to see to what extent what I'm going to say is documented within the scientific literature, the forthcoming book, the third edition of the Handbook of Religion and Health, the one that Sue mentioned earlier, will be coming out, I believe, in December of this year or in January of 2023. It is a massive text. It's about 2,000 pages. It's over, well, it's nearly 600,000 words. It has the very, very best research on religion and health that's been published prior to 2021. My co-authors are Tyler Vanderweel. Tyler Vanderweel is got his PhD in mathematics from Oxford University. He also has a PhD in biostatistics. He has an endowed professorship. He's a full professor at the Harvard School of Public Health. My second author is Dr. John Petit. John Petit is a psychiatrist at the Harvard Medical School. He's also a brilliant clinician. He's been involved in this area for many years. He does psychiatric work at the Dana-Farber Cancer Institute in Boston. And so the three of us have written this book and have reviewed the very best research. And Tyler Vanderweel is a biostatistician who is world renowned. He actually authors, he writes the books that statisticians learn from when they go to college and graduate school. So he is particularly in the area of longitudinal data analysis. This means following people over time and seeing whether or not certain characteristics predict various health outcomes over time. So he is the world leader on that, and he has very carefully looked at all of the research. There are literally thousands of studies reported in this handbook, and he has ensured and put his reputation on the line, as well as the reputation of the School of Public Health there at Harvard on the veracity of the research being presented. So I'm going to present some of that more recent research and also do a systematic review of research published in the second edition of the handbook, which was a systematic review of all quantitative research quantitative. That means, of course, that means somebody has measured religious involvement and has measured mental or physical health outcomes, and then have looked at the relationship between the two. So all of the research published in the English language since the 1800s is recorded in the second edition of the Handbook of Religion and Health by Oxford University Press. So if you go there, you can look at each of the studies, each of the 1,000. Probably there are about 1,500 studies in the second edition of the handbook, and they're all described. Every one is described in the appendix of the handbook and rated in terms of methodological rigor. Okay, so those are some sources. Also, my colleagues and I wrote a update on religion and psychiatry in the British Journal of Psychiatry, the Advances version, a couple of years ago. And then we also wrote an article on clinical applications, again, for the British Journal of Psychiatry. These articles are available for download if you're interested. And if you can't access them, just send me an email. I'm happy to send you the PDFs of those two articles. Okay, so let's go on. This is now I'm going to present a systematic review of the research out there. So depression, one of the most common emotional disorders in the world, and is more disabling than any other physical or mental condition that is listed in the ICD-12. I think there's the ICD-12, over 350 different diseases. Depression is related as the most disabling, second only to heart disease. Heart disease is the only condition, physical or mental condition in the world that creates more physical disability than does depression. So in our systematic review in 2012, we identified 444 quantitative studies, all of the research that have been published in the English language based on multiple reviews of the literature. And we found 444 studies published prior to 2010. Of those, 61% found that those who were more religious were less depressed, recovered more quickly from depression if they got depressed, and that religious interventions, religious treatments significantly reduced depressive symptoms when they were applied in randomized controlled trials. And of those 444 studies, a certain number, 6%, found that the religious person was more depressed, was having more problems with their emotions. But bear in mind that there are 10 times more scientific studies showing that religious people are less depressed, recover more quickly from depression than those that are finding that religious people are more depressed. This is a more recent study. This is a study of nearly 10,000 young people. These are young adults, average age of 23. And this is a up to 6-year prospective study. In other words, these 10,000 young people were followed for up to 6 years, and their risk for developing a depressive disorder was examined. Now, this study was conducted by the Harvard School of Public Health. It was published in the International Journal of Epidemiology a year or two ago, and they controlled for more than 24 predictors of depressive disorder in these analyses. And what they find was that those young people who attended religious services at least once a week were about 30% less likely to develop a depressive disorder over those 6 years. Suicide. Suicide is the most feared complication of depression. And in our systematic review, we identified 141 quantitative studies. Now, if you're interested in doing this, you could do this yourself. All you have to do is go to PsycInfo or Medline or Google Scholar and put in the year 2010 and then include everything prior to that. You will get exactly the same finding here because it was a systematic review. So of those 141 studies, 75% found less suicidal thoughts, fewer suicide attempts, and fewer completed suicide among those who are more religious. Let me show you some of the studies that have been done since that 2012 review. This is a study published in the British Journal of Psychiatry. This involved more than 20,000 Americans. This was a random sample of the US population, and they were followed for 18 years. And during this time, they looked at the risk of completed suicide among those attending religious services twice a month or more, compared to those attending services twice a month or less, or less than twice a month. So those attending religious services twice a month or more were 94% less likely to commit suicide compared to those attending less than twice a month. This was the finding after taking into account and controlling for gender, age, size of the household, previous suicide attempt, which is the strongest predictor of suicide, and drug use. And it was published again in the British Journal of Psychiatry. This is a study out of the Harvard School of Public Health. This is one that Tyler Vanderwill led and analyzed the data on. This is 90,000 women in the United States. They were followed for a period of, looks like 14 years. And during that time, they looked at the risk of completing suicide. And what they found was that those who are attending religious services at least once a week are, well, first of all, were seven times less likely to commit suicide compared to those who never attended religious services. And after you controlled for these 24 other predictors of suicide, there was an 84% reduction in risk. The hazard ratio was 0.16. And you can see that the 95% confidence intervals here are very tight. And that study was published in JAMA Psychiatry. JAMA Psychiatry used to be called the Archives of General Psychiatry and is considered the top biological psychiatry journal in the world. Now, this is another study published by the Harvard School of Public Health. This is looking at deaths of despair. Deaths of despair. Now, these are all women. These are all nurses. 66,000 nurses were followed for up to 16 years. It's part of the Nurses' Health Study. And they looked at the risk of dying from a death of either death from alcohol, drugs, or suicide. So those three causes of death. And those were called deaths of despair. And what they found was that women who attended religious services at least once a week or more were nearly 70% less likely to die from a death of despair during that 16-year follow-up. And what's interesting here is that there is a P for trend that is highly significant. A P for trend provides indication that there is a causal relationship between the predictor, this variable religious attendance, and deaths of despair. So statistically, they have methods of actually identifying causality or bringing resulting in about a 90% chance of causality through various methods of analyzing longitudinal data. And this is very important because you can't really do a randomized controlled trial in randomizing people to either attending religious services or not attending. It's just not ethical to do that. So aside from only a randomized controlled trial can prove causality. But again, methods have been developed to study longitudinal data that bring you about 90% to the point of causality. So this P for trend indicates that there a 90% chance that it is the religious attendance that is driving or protecting people from these deaths of despair. Okay, and in men, you find a very similar finding. This is a 26-year follow-up of 43,000 health professionals. These are dentists and pharmacists, optometrists. They actually did not include any medical physicians, but they have every other healthcare specialty in this study. And they, again, controlled for multiple predictors of death of despair. And what they found was about a 50% reduction in risk of dying from a death of despair among men. These are actually age-controlled analyses. And again, a P for trend that was highly statistically significant. And again, this was published in JAMA Psychiatry, the top biological psychiatry in the world, that had really not published any research on religion and health prior to about 2012. Okay, so let's look at alcohol use, abuse, and dependence. And clearly, again, this is part of the systematic review. Those who are more religious are just not using alcohol as much. They're not abusing alcohol. They're not becoming dependent on alcohol in between 80 and 90% of these 278 studies. And if you look at the higher quality studies, you are even more likely to find that religious people are less likely to use, abuse, and become dependent on alcohol. And again, these are all quantitative studies, and most of these studies are done among young people in high school or college, where they have their entire life ahead of them. The same finding is present for illicit drug use. There were 185 quantitative studies published in the peer-reviewed academic literature prior to the year 2010. And of those, 84%, 86% find that religious individuals just don't use drugs as much. And if you look at the experimental studies, you can actually do randomized controlled trials in terms of religious or spiritual interventions. And virtually they all show that the spiritual or religious interventions decrease illicit drug use. Now, this is a more recent study. This was an 18-year prospective study of about 500, a random sample of 500 US adolescents ages 11 to 16 who had actually been referred to Child Protective Services because they had been abused in the home or neglected in the home. So these young people are at very high risk for substance use later in life, actually later in their teen years. And what they found was that they asked these young people, how important is religion in your life? And those who indicated that religion was very important at the beginning of the study, over those 18 months, were about half as likely to develop a substance use disorder compared to those young people who indicated little or no importance of religion in their life. And this was a statistically significant finding after controlling for a whole host of other predictors. You can see these other predictors that were controlled for in this analysis at the bottom of the screen here. Anxiety and PTSD. In our review, we found that about half of studies found that those who were more religious experienced less anxiety. And we found that about 11% experienced more anxiety. Now, the reason for that more anxiety, we think, is because most of these studies were cross-sectional in study design, which means that the relationship was examined at a single point in time. Now, what we do know is that people who become more religious, people who are more anxious, more worried, that they are more likely to turn to religion to cope. So we think that the explanation for the positive correlation in these 33 studies largely results in anxiety driving religious practice. There's an old saying that there are no atheists in foxholes. So, when you're under a lot of stress, people tend to pray. They're dealing with something that is making them anxious, that they have no control over. they often tend to engage in religious practices. Now, this explanation is supported by the fact that of the 40 experimental studies or randomized controlled trials, that nearly 3/4 found that religious or spiritual interventions reduced anxiety when they were examined objectively. Here's a more recent study. This was a random sample of U.S. veterans. So this is a large study. It's the National Health and Resilience in Veterans study. This was more than 3,000 U.S. veterans were studied. This is a cross-sectional study, but it uses the Duke University Religion Index, which is 5 questions that have more to do than just with religious attendance. You know, prior to this, we've been talking largely about religious attendance, but there are other forms of religious involvement that don't involve going to church or synagogue or mosque. And so the Duke Religion Index has 1 question on religious attendance, 1 question on private religious activities, such as prayer or Bible study or study of the Quran or the Bhagavad Gita, whatever it is, the Holy Scripture is, and then 3 questions on intrinsic religiosity. So these 3 questions on intrinsic religiosity are measuring the person's relationship with, connection with God, basically. Basically, that's what they're measuring. So those 5 items then are the scores. They range from 1 to 5 each item, and then they're summed to create an index ranging from 5 to 25 or 27. I'm not sure what, but in any case, that total score was then divided in half, and then those scoring in the upper half were compared to those scoring in the lower half of religiosity. And these are the findings. In terms of lifetime PTSD, there is a more than 50% reduction in likelihood of that being present for those who were highly religious compared to those who were less than highly religious. Lifetime major depressive disorder was 50% lower among those who scored in the upper half of that religiosity index. Lifetime alcohol use disorder was about 1/3 lower among those scoring in the upper half. When you're looking at current PTSD, it was 70% lower among those who were more religious, and current alcohol use disorder, it was more than 70% less likely among those scoring in the upper half of this religiosity index. Again, this is a nationally representative sample of U.S. veterans published in the Journal of Affective Disorders, which is a pretty good journal here in the U.S. Well-being and happiness. Now, religious involvement is not only related to lower levels of various psychiatric disorders, but it's also related to the positive aspects of emotion in life, such as well-being and happiness. We reviewed the quantitative literature prior to 2012, identifying 326 studies published in peer-reviewed academic journals. Of those, nearly 80% found that religious people, those who are more religious, however you measure it, are simply happier than those who are less religious. They have greater well-being that you can actually measure quantitatively, and you can show that statistically. And of those 326 studies, only 3 studies, less than 1%, found that religious people were less happy than those who were more religious were less happy than those who were less religious. 3 of those 326 studies. So there are 80 times more studies that show that religious people have greater well-being than there are studies showing that they have lower well-being. And these studies are worldwide. These are not just in the United States. What about meaning, purpose, hope, and optimism? These are other positive emotions. Over 90% of studies show that religious people have greater meaning and purpose in life. They have greater hope when you in about 3/4 of the studies. greater optimism in over 80%. Again, this is a systematic review of research prior to the year 2010. Now, having meaning and purpose in life, having more hope, being more optimistic has clinical consequences in terms of motivation for self-care and efforts towards recovery among those who get sick or ill. So it really does have some clinical implications. Social support. Over 80% of studies, once again, find that religious people have more social support. They have more friends. They have more social contacts. They're involved in more group activity. Delinquency and crime. Of the 104 quantitative peer-reviewed studies, again, 80% report lower levels of delinquency and crime among those who are more religious. Now, that's probably not very surprising, but the fact is that this is documented now. This is all in the Handbook of Religion and Health, 2nd edition. And the 3rd edition, coming out here soon, does nothing but reaffirm these relationships based on research conducted in the last 10 to 12 years. Marital stability and satisfaction, less divorce, greater satisfaction in marriage, less spousal abuse, less cheating on spouse, more likely to have 2 parents in the home in between 80 and 90% of studies. And some of these studies are pretty large. This is a study, again, by the Harvard School of Public Health. This is a prospective study. It involves 66,000 women who were initially married 14 years previously, and then they followed them up over those 14 years, and they looked at who became divorced or separated. Again, this is the Nurses' Health Study. This is a multi-million-dollar study that is based in the Harvard School of Public Health, and they've been following these women now for many, many years. What they find is that those attending religious services at least once a week or more are between 40 and 50% less likely to divorce or separate. And again, you see this P for trend that is highly significant, suggesting that it is the religious attendance that is actually responsible for this causal relationship resulting in less divorce and separation. This is a model that helps to explain how religious involvement influences mental and social health. This is in the 3rd edition of the handbook. This is a bit of a peek preview. So religious involvement, as defined as religious attendance, frequency of prayer, frequency of scripture study, volunteering for religious reasons, religious education, religious devotion, religious coping. Now, this includes people from all different faith traditions, Christians, Muslims, Jews, Hindus, Buddhists, that people who are more religious, that across the lifespan, it appears that there are mechanisms by which this religious involvement influences mental and social health. It begins, now listen to this, it begins, this effect on mental and social health begins prior to conception, based on the behavior of the parents. It's now been shown that the behavior of the father, that the quality of the sperm is actually influenced by the behaviors of the father, particularly their use of drugs and alcohol, which are lower among those who are more religious. And then once conception occurs, as the baby grows and as the brain grows, it's the behavior of the mother that influences that brain growth. And we know from research outside of this area, from standard secular research, that brain growth is affected by the habits of the mother. The mother's drinking, using drugs, etc. It affects the brain of the child. If the mother is stressed out because the mother doesn't have a spouse to help them, maybe they have several kids and they have to work and they're stressed out over work, they don't have the support of a spouse, that they're going to, those physiological hormones are going to adversely affect the growing brain of that child in the womb. And consequently, when that child gets to be an adult, their stress response is adversely affected. So based on secular research, we know that those factors are occurring. And we also know now that mothers and fathers who are more religious are less stressed. They have more support. They're less likely to use drugs and alcohol. They live healthier lifestyles that give that child in the womb a better chance of then ultimately leading a life where they can cope with stress and other social issues. So it begins prenatally, and then it occurs once the child is born. Then religious groups tend to encourage childbirth. So one reason, if you look at Islam, for example, they have large families. You look at Christians, Catholic families, large families, because children are really valued. People want a big family. They love children. Now that's not just true in religious families. There are many non-religious atheist families that welcome their children, that love children. But in general, research seems to show that the more religious a person, a family is, the more welcome the child is when they're born. Even looking at retrospectively research. So in any case, they're welcomed, and during that first year of life, being welcome is critical for the development of basic trust on which all future relationships are based. Later on, as the child grows and gets into the teenage years, religious families tend to monitor children more than less religious families. That's been shown that religious families are more likely to check on the child. Where have you been? Who are you hanging out with? And consequently, the children hate it. They hate it, but they don't get away with things. So they're less likely to start using drugs, starting to smoke. They are less likely to get involved with a bad peer group, again, because they're more closely monitored. And then as people grow older and they get into middle age and adulthood, then they start raising their own families. And that's when it's important with regard to coping with the stress of marriage and parenthood, and then physical illness. As people grow older, then you have to really have a strong coping behavior. When you get sick and disabled, you can't do the things you used to do. You start having chronic pain, that's really makes life difficult. And it's there that religion really begins to shine. That's the area that I kind of started out with. And I discovered just from my clinical practice as a family physician, that among older adults who had a strong religious faith, they just did better. They just did better emotionally and physically. Okay, so just a few words on religiously integrative psychotherapy. So as a result of all of that research, thousands of studies showing these connections with better mental and social health, researchers have begun to integrate people's religious values and beliefs into psychotherapy. And this is a review of 97 randomized controlled trials published in the Journal of Clinical Psychology. This was in 2018. Kaptari was the lead author. They looked at that, involved over 7,000 subjects. And what they found was, compared to no treatment, religious spiritual adapted psychotherapy resulted in significant improvements in psychological outcomes with an effect size of 0.74. 0.74 is a large effect. If you look at effect sizes, clinically significant effect sizes, 0.20 is small, 0.50 is moderate, and 0.80 or more is considered large. So the average effect size here is large based on this review of these 97 outcome studies. When compared to any form of secular psychotherapy, the effects were likewise similar. So you see here, there is a small to medium size difference favoring the religiously integrative therapy. And then in the more rigorous additive studies, that's where religious or spiritual involvement is added to a standard treatment and compared then to the standard treatment, you find that the effect is smaller. Okay, so here are examples of three different ways of religiously integrative therapy. So first of all, I'll look at cognitive behavioral approaches for emotional disorders. then religiously integrative cognitive behavioral therapy for depression and anxiety. And then we'll look briefly at religiously integrative cognitive processing therapy for moral injury and post-traumatic stress disorder. So we know that the cognitive behavioral model is the dominant model today in counseling and psychotherapy. People experience events, they perceive the event as either negative or positive, then they have thoughts about the event, which stimulate powerful emotions, which then cause people to act and do things. And those behaviors then create more events that affect perceptions, thoughts, and emotions. And so this is the model of cognitive behavioral therapy. Now, this is how it works. Negative emotions are generated by negative automatic thoughts, dysfunctional, maladaptive, inaccurate assumptions about the world, exaggerated patterns of thought not based on fact, and negative behavior that follows. Now, what these religiously integrative therapies do, they help the person become aware of what they are doing, that their painful emotions are being generated by their negative thinking, and they help the person to think differently. They do cognitive restructuring based on what the scriptures say, what the scriptures of the person say, the Holy Scriptures. So we've developed actually a structured method of, it's a structured intervention and tested it in a randomized controlled trial. And we have versions of this therapist manual, participant workbooks, lecture, and training videos, all available for free at our website right there. And we have versions for Christians, Jews, Muslims, Shia Muslims, Sunni Muslims, Urdu Muslims from Pakistan, Hindus, and Buddhists. So these are manuals and that describe 10-session religiously integrative cognitive behavioral therapy. For the Christians, it's based on the Bible. For the Jews, it's based on the Torah and the Talmud. For the Muslims, it's based on the Holy Quran. For the Hindus, it's based on the Bhagavad Gita. And for Buddhists, it's based on the Dhammapada. The Dhammapada is the teachings of the Buddha. This is our study based on a randomized controlled trial. We found a large effect size for the religiously integrative psychotherapy. That's in the red, although there was no significant difference from our conventional cognitive behavioral therapy. There was a small difference. The Cohen's d was 0.12, but it was not significantly different at the endpoint. This is the endpoint of the study at 12 weeks after 10 sessions. But look at the overall effect sizes. Overall effect size. 0.80 is considered a large effect. This effect size was 3.02 for religiously integrative cognitive behavioral therapy over the 12 weeks. So this is a large effect size that dropped the Beck Depression Inventory scores by more than 50%. Now, here are, I really would like to end now with just saying a few words, because I want some time for discussion, question and Q&A. I suspect there are some questions about what I've reported here. There has to be some questions. But there's also a spiritually, religiously integrative intervention for moral injury and PTSD that our research team that has developed, both for licensed professional counselors and psychologists, and also for clergy or chaplains. And moral injury is something that occurs in the setting of severe trauma. A lot has been talked about this recently. It is the internal conflict that results from a transgression of moral values. So this is in the military. This is particularly common. More than half of people who have been in combat experience moral injury from killing other people. That creates all sorts of emotional stress as people, it's not only killing, but doing violence to others, witnessing violence, not being able to protect the innocent. being put in a morally compromising position by one's superiors, witnessing others violate moral codes, dehumanizing the enemy, plundering the enemy, rape, torture. All of this involves transgression of moral code during combat situations. Consequently, there is moral injury. There are the religious symptoms of moral injury, religious struggles, loss of faith, and then there are the psychological consequences: guilt, shame, moral concerns, feeling betrayed, loss of trust, difficulty forgiving, loss of meaning and purpose, self-condemnation. These are indicators of moral injury. Moral injury is known to influence PTSD symptoms, depression, anxiety, substance abuse, relationship problems, physical disability, even pain. And in particular, it's a predictor of increased suicide. We're having a lot of problems in the military right now, in the US military, with regard to suicide. And part of that is because of this moral injury that we think is very common and is not being treated. So we've developed treatments. Now, moral injury is different from PTSD. There is some overlap, but it's a distinct syndrome separate from PTSD. And by the way, all of these slides are going to be available in PDF form for anyone who's listening today. Sue will send them to you. Again, the PDF of all of these slides. So we have a measure that we were the first team to develop a symptom measure of moral injury. There's a 45-item version and a 10-item version. I did a review of this in Frontiers in Psychiatry a couple of years ago, and it's downloadable. You can download it for free from that website. Here's our spiritually integrative CPT intervention. It's 12 in-person sessions. We have a broad spiritual version and also religion-specific versions. If you want to know more about it, go to this article at the bottom of the screen. You can get this for free download at that website. Here are the 12 sessions. Don't have time to go through them. And that's where to get the manual and the both the therapist manual and also the patient workbooks. Send Michelle Pierce. She's one of my my co-authors on this. She's at the University of Maryland now. She'd be happy to send you the workbook and the therapist workbook and patient. So in conclusion, religious involvement is related to better mental, social, and behavioral health and improves these aspects of health over time. Religiously integrative psychotherapeutic interventions have been developed for many disorders, especially depression, anxiety, and other forms of internal emotional distress. If you want to know more about this, as I said earlier, go to our website for the religiously integrative cognitive behavioral therapy manuals in the 5 different religions. I have a book out, Religion and Recovery from PTSD, that also describes some of the issues about moral injury that I talked about, and then Michelle Pierce for the spiritually integrative cognitive processing therapy. And we have a 12-session pastoral care version of the intervention for moral injury, again, in 5 different religious traditions. It's 12 sessions, weekly sessions, 50 minutes long, targeting each of the 10 symptoms of moral injury. And we have a 15-item mental health spiritual history. Every single psychologist, counselor, whoever is doing mental health needs to take a mental health spiritual history. And this is actually endorsed by the American Psychiatric Association, the Royal College of Psychiatrists, and the World Psychiatric Association. All of these major world psychiatric associations endorse the taking of a spiritual history to identify the spiritual strengths, and sometimes religion and spirituality can be related to the mental disorder itself, can actually be generating or worsening a mental disorder. So the therapist has to know about the religious and spiritual beliefs of the patient, and taking a spiritual history is becoming the standard of care in the mental health field. Okay, this is a 15-item version. Again, you can get the PDF. It's from my book that I wrote earlier, but you can get the PDF from Sue that has all of these. You can sign up for our e-newsletter. I send it out every month. It's for free. It looks at the latest research in the field. We have a summer research workshop held every year. This will be the 20th year, the 19th year we've done this. We have people from Duke, Yale University, Emory, Johns Hopkins coming to train people on how to do research in this area. I'd love to see some research coming out of Tasmania in this. If you're interested in coming here to Duke to get this training, just send me an email. There's my email at the bottom. And here's a book that summarizes the research workshop. If you can't come, you could get this book that describes how to do research in this area. Here's our website. And I'm done. It's the end of the hour, but I'm happy to stay for 10 minutes, for any questions that anyone might have.
Look, thank you very much, Dr. Kay. That was incredibly comprehensive, and it certainly raised many wonderful points, bringing religion and spirituality into it. I'd just like to say it reinforces to me the urgent need for the secular aspect of society to start looking at the spiritual aspect. What I would like to ask you, if you don't mind me asking you a question first, have your studies been based on the indigenous cultures or mixed races, or purely, the sort of Western influenced individuals?
There is a large gap in this area. There are very few studies that have actually looked at indigenous cultures and communities. This is an area that could very easily be studied, and it would be the first time it's ever been looked at. So I couldn't agree with you more. This is a very high priority area. There's been a little bit done in American Indians, not much though. There is a measure for American Indians that has been developed, recently was published, measuring spirituality within the American Indian tradition. But there are so many smaller groups that have different traditions. It's very difficult to develop a measure to generalize across all different indigenous groups. So you really need to develop measures of spirituality and religion in those groups, and then you need to look at the outcomes. So this is a huge area for future research.
Thank you. Does anyone have a question for Dr. Kay?
I do. Hi, Dr. Harold. I wanted to ask you about moral injury. Do you consider survivors of sexual abuse and incest, does that cover moral injury, or are you looking at people, like you said, first responders and so on?
And the answer to your question is yes, absolutely. In fact, we are developing now with Harvard and Duke are now developing, we're looking at adverse childhood experiences. And this, we're having meetings right now to develop measures for people specifically. Most of these measures have been developed in the military and for first responders, but we're now looking at developing measures and interventions for people who have experienced adverse childhood experiences, including abuse within the church. So this is now, you are right, you are right on the cutting edge here, because this is over the next 5 years. We are going to be doing some extensive research in measurement development as well as in developing interventions for these individuals that can be used by clergy in particular in addressing these issues.
Okay, thanks. And our military is the same. We're very distressed about the high number of suicides, and the government's slowly starting to look at it, but as you say, more needs to be done.
Exactly.
Yeah. Okay, thank you.
Anyone else for a question?
Yeah, I was interested to hear about the moral problems that happen with soldiers being forced to go out and kill and take people's lives. I was just very glad that I wasn't conscripted, because I've got a strong Christian values, And I'd hate to have to kill somebody
Mm.
in the line of duty or even self-defense. So it's interesting to see all those things that can be affected by the moral breaking, as well as PTSD.
Mm.
So yeah,
You know-
thanks
you
for
know-
sharing that, and thanks for sharing all those resources too to help people.
Mm.
Thank you, Milton. And by the way, what we're seeing in Russia and the Ukraine with the Russian troops
Mm.
collapsing, that is exactly what's going on. These individuals, these Russian conscripts are in battle, and they're experiencing moral injury and traumatic stress. And that's
Yes.
why the Ukrainians are advancing. Because they're, the Russians know that what they're doing is transgressing moral values in hurting and affecting these poor Ukrainians. So that I think is one reason why you're seeing Russian troops deserting and taking off, is because they see that this is something wrong.
Mm. Mm.
And that must surely tie in with the Ten Commandments, where, God has said, thou shalt not kill. So those in the military who are defending or having to go into situations of conflict, and but particularly if they're led into immoral behaviour, which appears to be becoming increasingly part of the evil side of the war, the profound effects must ricochet right through the generations until they're actually halted through a spiritual cleansing.
That could very well be. War is terrible. It's a terrible thing, but sometimes it's necessary to prevent evil,
And that's
evil
true
and,
too.
and maintain the freedoms, that we all cherish so desperately.
Mm.
And, so it's a terrible thing, and it does ricochet across generations. That traumatic stress, that moral injury definitely affects marriages, and it affects children as well. So it's a big deal. It's a really big deal.
Before I forget, Ruth apologised because she dropped out. She said she was very sad to have lost her connection, but I'll send on your presentation to her. There's another question I'd like to ask you, Dr. Kay, and it's in relation to the negative impact of religion. Is there perhaps a correlation between religions that are controlling, where there's a lot of ritual, a lot of rules and rituals that are mandating your worthiness on what the church is, the church expectations rather than the expectations of the Creator, and therefore individuals who are of perhaps a more sensitive nature trying to do the right thing but being led into this very religious way of being end up sort of having a lower sense of worth because they never feel they're actually good enough to be worthy of the calling.
We have very little research looking at comparing different religions, and it's very, very difficult to do. What we do know is that devout members of different religions, most of the research has been done in Christianity, but it's also, there has been research done in Islam and Judaism and Hinduism and Buddhism, that devout believers and practitioners seem to derive mental and social health benefits from those practices. And within Christianity itself, we really don't know, because of selection factors. People self-select into different groups, and for what one group may seem as very neurotic, to another group may in fact be very healthy for that particular person because of their self-selection. So it's very difficult to compare groups, but in general, that religious faith systems that encourage love of God and love of neighbor, these are healthy religious belief systems. Love of God, love of neighbor, and it's balanced, a balance of love of God and love of neighbor. So that is what in general is related to better mental and social health outcomes.
Yes. Which
Okay,
is
I'm
really
gonna have
about
to go.
relationship. Yes.
Yeah, I have to go
Thank
too.
you very much. It's been wonderful